Welcome, everyone. My name is Kathleen Crivero, and I am a director of the Center for Immigrant, Refugee, and Global Health, along with Diana Romero and Heidi Jones, who are also with us this evening. The Center for Immigrant, Refugee, and Global Health is embedded in the City University of New York Graduate School for Global Health, for Public Health and Health Policy. And it has several objectives. Among them is to raise the voices of local practitioners, connect with like-minded institutions locally, nationally, and globally, and serve as a resource for exchange and best practice on migrant health policy, both domestically and transnationally. So we are very happy and pleased and honored to have with us tonight Masako Tanaka, who my colleague Diana Romero will introduce. But Dr. Tanaka is an expert in many things, including sexual and reproductive health, and giving that a migrant perspective and lens, which is exactly the kind of person and academic work that the Center for Immigrant, Refugee, and Global Health seeks to highlight and give visibility to, and we're very honored to have her at CUNY for the next couple of months. So let me turn over to Diana.
Thank you, Kathleen, and hello, everybody. Good morning or good evening or good afternoon, depending on where you are. On behalf of myself and my colleague, Professor Heidi Jones, I am extremely pleased to introduce Professor Masako Tanaka. Professor Tanaka is a professor at the Department of Global Studies at Sophia University in Japan. This spring and summer, we have the great privilege of hosting her here as a visiting research scholar. And that is here, as Kathleen said, at the City University of New York School of Public Health. Professor Tanaka has been researching contraceptive options and policy gaps related to reproductive health and rights between Japan and sending countries of migrants. She's conducting similar research here on the topic, but specifically focusing on Nepalese migrants in New York City. Before I turn it over to her for her presentation, I just want to express our gratitude to the many CUNY School of Public Health staff who have assisted with her being here this spring and summer, between human resources and public safety and IT. There have been so many supportive and helpful staff here at the school who have made her arrival here and integration into the school as smooth as possible. So I'm just really grateful for that, because we know sometimes that can be very bumpy. So with that said, I turn it over and very much look forward to your presentation, Professor Tanaka.
Hi, good evening and good morning. First of all, I want to express my hearty thanks to Heidi Jones and Diana Romero and for other staff who helped me a lot last 1 month. I arrived in New York 20th of April and I could get IRB approval today. So I'm very happy today. And Ansley, she helped me a lot during the process. And thank you for hosting today's program, Elizabeth and Catherine. Thank you very much. So I want to start my presentation, and please allow me switch off my video because my Wi-Fi connection seems to be not very strong. So today I'll talk about migrants' reproductive health service and pregnancy-based discrimination in Japan. And first half is a kind of background and context regarding the immigration system and so-called maternity harassment in Japan. I think in English, in US, maybe pregnancy-based discrimination is an appropriate word. But in Japan, we call it maternity harassment. This word is so common. So I use this maternity harassment today. And I will talk about state of reproductive health service in Japan. Probably it will be interesting for you to know the abortion law in Japan. And the second half, I'll talk about my research in Japan and ongoing research in New York City. So at the beginning, I want to share the story of one of the Vietnamese migrants case, which is now at the Supreme Court case. And I will show a 2-minute video clip.
A foreign technical trainee is appealing to a conviction to Japan's highest court. 23-year-old Lei Thi Lin was convicted of abandoning the bodies of her 2 stillborn babies. Her lawyers presented the grounds for her claim to the Supreme Court on Monday. It happened at her dormitory in Kumamoto Prefecture in November of 2020. Lin is from Vietnam and was working at a farm. Lin wrapped the babies in a towel and put them in a box. She named them in a note, writing, "Please rest in peace." She put the box on a shelf in her room. In January, the Fukuoka High Court ruled that the act of keeping the bodies in her room for about 33 hours does not constitute the crime of abandoning them by omission, but it stated that because the defendant used duct tape to seal the bodies in a double box, she was guilty of trying to hide them. The judgment also noted her personal circumstances. It stated Lin tried to hide her pregnancy in order to continue working and send money to her family in Vietnam. Lin was eventually sentenced to 3 months in prison, which was suspended for 2 years. This January, she appealed to Japan's top court. On Monday, she spoke to journalists online.
I was afraid of being sent home when I found out I was pregnant. I absolutely did not hurt, abandon, or hide my twins.
Lin's lawyers say many technical trainees who get pregnant are still under pressure to leave Japan.
警察や検察が
If police and prosecutors could have a better understanding of what disadvantages a technical trainee would face if she got pregnant, and if they could have a better understanding of the circumstances in which she gave birth, I don't think the arrest or the indictment would have happened.
というのは、ないというふうに思うんですよね。
The Supreme Court will decide whether to accept Lin's appeal.
Okay.
A foreign technical trainee is appealing to a conviction to Japan's highest court. 23-year-old Lei Thi Lin.
Okay, so I will back to my slide. I have been supporting this case because her case should not be only treated as a criminal case. Maybe we should look at the availability of service and many things behind this case. So she came to Japan in 2018 under the technical intern trainee program. I will talk about it later. And 2020, she confirmed pregnancy with a test kit, but failed medical abortion with the abortion pill she got through Vietnamese community's SNS. So far, she has never been to hospital or clinics until she was arrested. So technical intern trainee program is a bilateral agreement between Vietnamese and Japanese government, and it's quite complicated system. Vietnamese sending organization recruit potential intern trainees, and they will work for Japanese accepting companies. However, supervising organization always supervise the technical trainees, and semi-government organization for technical intern training program supervise this supervising organization. So there are 3 different layers, but this is quite dysfunctioning. And US Department of States every year give warning to Japanese government to stop this modern day slavery, because in 2020, 8,000 TITP participants disappeared from their job. And last year, TITP report said some labor contract featured illegal automatic repatriation clauses for the intern who became pregnant or contracted illness while working in Japan. So I expect this year's TIP report give more strong recommendation against Japanese government. And TITP participants experienced different types of maternity harassment, not only forced contract on penalty, resignation, or deportation. In some cases, there is some rules not going out from their dormitories or unfair rules on dating, or sometimes forced pregnancy check, forced abortion, or forced deportation. So such pressure encourages pregnant trainees to choose medical abortion without doctor's supervision. It is very easy to find abortion pills sold on the Vietnamese community's SNS. This photo is one of the examples my Vietnamese student found. And usually it costs US $50 to $60 only, which is much cheaper than ordinary medical facility in Japan, because usually we have to pay 200 US approximately. And today, there are around 3 million of migrants in Japan. Around half of them are women, and 70% of them are reproductive age. However, the large majority is technical intern trainee and student. So if you look at the immigration rule, there are two different types of residential categories in Japan. One is based on status, like PR holders or long-term resident, mostly Chinese, Korean, Brazilian, those who have been in Japan for many years. And the other half is based on activities like TITP holder program or student or dependent. And if you look at their gender and age, almost 100 of TITP and student women are reproductive age. So it is very easy to understand they are the most vulnerable population among migrants. And I choose China, Vietnam, Nepal, Indonesia, and Myanmar for my research because as a top 10, among the top 10 countries, Philippines, Korea, Brazil, Taiwan, these 5 countries do not have many TITP and students. For instance, Brazil is the 5th largest foreign community in Japan, but there is no TITP visa holders and only 150 for students. However, for instance, Vietnam, 92% are either TITP student or other activity-based visa. As same, Nepal, 93% are similar kind of vulnerable visa category. So I paid attention to these 5 countries. And also, I think these 5 countries are very diverse in terms of religion and culture, because Indonesia, the majority is Muslim, Nepal, majority is Hindu, and Myanmar and Vietnam, its majority is Buddhist. And now I'll talk about the background to state of reproductive health service in Japan. This photo I took at the small shop called Little Yangon in the heart of Tokyo. It looks like very similar kind of grocery shop in Jackson Heights in New York City. And the left side is the entrance, and the right photo is one of the part of the shop. And I put red circle, the medicine of oral contraceptive or morning after pill. Oral contraception only costs $3 US. Morning after pill is only $5. And when I asked the shopkeeper, customers are not only Burmese, but Indian, Nepalese, other nationalities, And he said the large majorities are Japanese. In terms of contraception, oral contraceptive pill, Japan was the last country among the UN member states that approved OC in 1999, same times as North Korea. It was a half year after the approval of Viagra. It took 44 years after the OC was developed in 1955, while the Viagra was approved in Japan a year after its market release in the United States in 1998. So at that time, there was a hot debate and also international pressure why Japan give permission to Viagra so quickly, while there is no OC available at that time. And it is still prescribed medicine, not an over-the-counter drug. And health insurance applies only to the person suffering from menstrual disease. So if you want to use it for contraception, it is not subsidized by health insurance. And as for emergency contraception, morning after pill, 2011, ministry approved it, but it is also prescribed medicine. And it's almost impossible to get it over the weekend because medical facilities are closed. So we are advocating to switch it as OTC last few years. And this photo shows a civil society group campaign on improving access to emergency contraceptive. And we had a dialogue with women MPs. As for abortion, the Penal Code 29 criminalized abortion in 1907, but this very old penal code still exists today, and it punishes women and the practitioner both. In 1948, after the Second World War, eugenic protection law replaced national eugenic law during the Second World War period. It allowed abortion for pregnancy in cases of rape and voluntary and involuntary sterilization of people with intellectual disabilities. At that time, Prefectural Eugenic Protection Council have a right to approve abortion, not with the consent of the woman or her spouse. And in 1996, Mother's Body Protection Law replaced this eugenic protection law, and it allowed abortion in the case of rape and physical and economic reasons. So today, abortion is not legally difficult in Japan, but it requires spousal authorization for married women, which is still barrier. In terms of method, medical abortion pill has not yet approved, and surgical abortion, D&C, is still common, though WHO has been warning Japanese government not to use this, but to switch to manual vacuumous aspiration. And it costs minimum $1,500 to $4,000 US. It is very costly. And last week, civil society organization had a dialogue program with ministry. But if you look at the photo, it looks like boys' club. And all male technocrat team explained the ongoing screening process of the abortion pill. So you can see why Japan is so behind of allowing medical abortion, because there is it's a kind of political issues. There is no women's representation in this circle. So due to these reasons, in Japan, very few choices of women-centered methods. And what's worse, the prevalence rate is the lowest among these surveyed target countries. And China, Vietnam, both had very strong population policies. So contraceptive prevalence rate is very high. And even Indonesia, injection is very popular, Myanmar too. But in Japan, condom is almost all one option, and there is no implant or injection. So you can imagine how difficult for female migrants to get access to service. And the largest service gap may be between Japan and Nepal, because in Nepal, almost all items are free of cost at government and NGO clinics. And from 2016, abortion also became free at government clinics. So in Nepal, not only contraception, but abortion too are free of cost. So that is the reason behind I paid attention to Nepali communities in Japan and in the United States. So in sum, migrant women face barriers to fulfilling sexual and reproductive health rights in Japan. In general, they have language barriers, cultural and religious barriers. I think it happens in any countries, but in Japan, there are two different types of legal barriers. One is undocumented pregnant women cannot join health insurance scheme. So no public support at all applied to them. So still, they are entitled to get maternal child health book, Boshi Hoken Techo, but there is no subsidy for prenatal care and delivery cost for them unless they apply for a special support scheme, which is very difficult even for the supporters to get approval from municipal office. And as I have said, no provision of legal status for children born to migrant women under TITP and student visa categories. So this is one of the negative aspects why TITP and student are not going for delivery, but choosing abortion. And the last one is the service gap, but I'm going to explore more. So I have started my research with four A framework. Accessibility means distance and barrier. Affordability is about price and financial protection under health insurance scheme. And availability is more on timing. And acceptability is quality of service and whether they have any discrimination or not. And when I look at previous studies, besides language barriers, one of the study done by PhD student who worked with me in the past, she found only 5% of Nepalese migrant women get consultation on family planning at health facilities in Japan. It really made me surprised because most of them are reproductive age, but only 5% have been to health facility in Japan for family planning. And also more than 10% of Nepalese migrant women experienced abortion in Japan. As you see, medical abortion is unavailable and surgical abortion is so expensive. So I wonder how and where they get abortion. So since 2018, I have been conducting research on this topic. However, when I finished my desk research, COVID pandemic started, so I couldn't do much on face-to-face interview or key informant interview because service provider in health institute were very busy those days. So I conducted focus group discussion with some facilitators from their own language community. The top photo shows Burmese female doctors explain about the female organ to their peers. And another photo shows male service provider facilitate discussion program for male groups. And when we start that topic, I usually encourage participants to write their own bodies. And it gives a lot of interesting insight for me, how they understand their own body and their functions. And I produced YouTube video clips on learning reproductive health in Japan in 4 different languages. And each language community disseminate information. And I conducted online survey, and there were 4 different sections and 34 questions in total. The first part is about basic information about the participant. The second part is about their migration history and current situation. The third part, C, and the last part, 4, is a comparative studies of their access to reproductive health service before and after migration. Luckily, I could get 536 participants. The largest number was Vietnam, followed by Nepal, Myanmar, Indonesia, and China. And it was very difficult to reach out TITP visa category holders because they have very limited access to Wi-Fi. But still, I could get 40 participants among them. Surprisingly, 12 TITP Vietnamese women, all of them replied they experienced maternity harassment, either by forced contract or verbal contract or asked to pay penalty. It really made me surprised because even the number is only 12, it was 100% of them. However, it is not limited in TITP. Even students or non-Vietnamese like Nepalese or Burmese also experienced maternity harassment. And regarding contraceptive method used before and after migration, I didn't see much changes among male participants. However, many women said male condom, rhythm method, withdrawal, popular method for them. I mean, increased after their migration to Japan. And interestingly, 4 women keep using implants in Japan, and 2 of them said they applied implant because they are coming to Japan, where is no preferred contraceptive is available. And others among sterilization, some did the sterilization as preparation for migration to Japan. So those who already have information and availability of preferred contraception, they themselves prepare and get either implant or did sterilization. And when I asked, how did you get contraceptive device and drugs in Japan? 137 respondents said they got it in medical institute in Japan, but 87 responses were something different, either through the internet, maybe from their own community, or they brought it before migration to Japan, or they asked their family or friends to send them from their own country, or they bought the shop owned by their own ethnic group, like the shop in Little Yangon. And the reason behind not using contraceptive in Japan, some replied they cannot find own preferred options or too expensive or do not know how to get it. And interestingly, none of them said religious reasons. And on the whole, I didn't see significant difference by religious group. That was very interesting point because I thought maybe Muslim, Catholic have different opinion about contraceptive use in Japan. But so far, I didn't see much difference by religious group. And I asked about experience of unintended pregnancy. And all 5 countries participants experienced unintended pregnancy in Japan. And around half of them delivered, and 12 of them did abortion, and 4 of them still not yet decided. But the highest number was Nepal. And location of delivery and abortion, actually, this survey was conducted at the beginning of pandemic started. So there are a certain number of people who could go and back to Japan. Therefore, some of them replied they did delivery, abortion in their country of origin. However, probably in 2020, if I did this survey in 2021, maybe they could not choose going back home for delivery or surgical abortion. And as I said, medical abortion is not allowed in Japan, but 2 of them replied they choose medical abortion in Japan. So in sum, I think in terms of availability, some migrants cannot find preferred option in Japan, and they do not have easy access, and 20% of them did not get contraceptive device at pharmacies or medical institutions in or of Japan, which means they still rely on supply from their own countries. And in terms of affordability, certainly the price gap made a difference if they move from their own country to Japan. And as accessibility, some women prepare their contraceptive or sterilization before they migrate to Japan because they feel comfortable doing so where they do not have language barriers. And regarding unintended pregnancy, I cannot say whether it is very high or not, because there is no statistics of unintended pregnancy of Japanese women. So, however, probably ratio of unintended pregnancy of this group may be relatively high. And migrants use abortion pills in Japan without doctor's supervision. So this kind of service gap in contraceptive and abortion service between their countries of origin and their destination make migrant women more vulnerable and at risk. So that's why I wanted to do similar research in New York City. And Nepali is not very large group in New York, but it is one of the fastest growing ethnic group in New York City. And they are around 12,000 now. And on coming Sunday in Manhattan, Nepali group will do Nepali parade. And ongoing research, I apply same framework and almost same methodology. And luckily, I could find very well-organized Nepali women's, Nepali speakers group called Adhikar. Majority of members are either babysitter, domestic worker, or maid workers. And also, there is very nice Sherpa Gompa formed by United Sherpa Association in Jackson Heights. And also you can find many Nepali restaurants in Jackson Heights area. So I'm going to reach out Nepali population through these channels. I will conduct key informant interview, in-depth interview, and online survey. So I welcome your suggestion for my research in New York City, and I'll be very happy to talk more about Nepali community with Nepali meals, maybe in Jackson Heights. So thank you for your attention to my presentation.
Thank you so much. That was so interesting. I'm going to open it up for questions. Again, I'm Heidi Jones. I'm a faculty member at the CUNY School of Public Health. I'm really excited to have Dr. Tanaka with us. So do we have questions from the audience? And you should feel free to unmute yourself or to put them in the chat, either way. Maybe I'll get us kicked off. If here we go. Someone just feel free to type your question. Yeah. So I was curious about what you're calling maternity harassment. I'm wondering how it's interesting to me because in the US, there are very strict rules about asking anything related to pregnancy. It's illegal to ask anything related to pregnancy during any kind of employment interview. and to have that affect employment in any fashion. So I was just a little curious about how is it for Japanese women, and is there like a real disconnect between migrant women and Japanese women, or is it sort of vestiges of some unfair laws for all of Japan that have not yet been changed? Or
Thank you for your question. Maybe we are far behind the US, but there is a law again which should not allow asking such kind of question, both sexual harassment and maternity harassment. But that law's applicability was first to the very big company like Toyota or Panasonic. And gradually, it will reach to small enterprise. So from last year, it was also applicable to the small enterprise. But still, it is enterprise level. And TITP workers are working for farm or fishery, and those places are also enterprise in legal entity. But employer does not perceive themselves should follow the compliance, because it seems like they are just hiring them as a part of family business. So there is a kind of gray zone to apply that law. And however, we advocate there should not be any discrimination against migrant women, no matter whether they are working in family business or not. But still, those who are working in those circumstances, themselves also think, oh, I'm not working for company, I'm working for particular family business. So they are not trained to exercise their rights at all, even though they have 3 or 4 months training period, both in the source country after the arrival. So we are advocating why the government of Vietnam or Japan don't provide so-called rights-based education as a labor. That part is extremely weak, not only migrant worker, but Japanese population too. Because when I talk to my ex-student, some of my ex-students also said she was asked whether she already get pregnant or not at workplace. But even those who are highly educated university graduate cannot tell anything against on the spot. That is one of the very weak part of Japanese society, I think.
interesting. I have one follow-up question, and then it looks like we have a question from Kathleen as well. But do the TITP immigrants have access to other healthcare? Is it only like, do they have some kind of insurance, or what is, like, if they get sick, not pregnant, how is that handled? And is it just the pregnancy where the gap occurs?
They should pay health insurance from their own pocket, or if their employer will not share the cost. It is national health insurance. And at the beginning, most of them start to pay it, but since they are quite young and healthy, usually they stop paying after 2 to 3 months. And when they are really sick and when they want to go to hospital, they feel, oh my God, I haven't paid the last 4 months. If I don't pay this penalty, maybe I will not get, I cannot get insurance service. So it made them, it will discourage them going to the hospital. The health insurance payment is number one. The second problem is the level of Japanese TITPs, migrants are very, very poor. Maybe it is enough for their daily routine work, but it is not enough for to explain their health problem in front of doctors. So usually the supervising organization needs to provide interpreter, but they also discourage the TITP migrants to go to hospital because, okay, I'll buy medicine for you. Please take a rest for a few days. Because for them, providing a certain time, like 3 to 5 hours as interpreter is costly for them. So this health insurance and language made them difficult to access to healthcare service.
I know Kathleen has a question, but I have a really quick follow-up to that, if you don't mind. So let's say they do purchase the health insurance or their employer splits it with them. They're still not, if I understood you correctly, they're still not, health insurance doesn't cover contraception though, right?
At all.
I just wanted to be clear. Okay, thank you.
Great. And from Kathleen, we have, is contraception an issue that Nepali women in New York City are willing to discuss easily? Are there cultural factors that you need to take into account? And how will that affect how you approach the research?
I started informal interaction with them, and probably they do not talk a lot each other among them. But when I shared my research findings about their peers in Japan, many of them started to talk about their own story. For instance, I heard implant in US is effective only 2 to 3 years. I'm not sure whether it is true or not, but Nepali women believe implant, which they will get in Nepal, will effective for 5 years. So I heard they still prefer to go to Nepal to get implant there because it will be effective for 5 years. So they started to tell that kind of story. So I think, of course, they feel very hesitant to talk about it in front of others. But when I share my findings in Japan, they are very curious how their peers are doing in Japan, and they start to tell similar story in New York.
Thanks. Do we have other questions?
I don't want to get in the way of other questions, so I'll wait a second and we can see.
Go ahead.
Okay, yeah. So I guess this is maybe a comment, and then I'm interested in your thoughts about it. As you were making your presentation, it just very much reminded me of really glaring contradictions that we have here in US policy when it comes to access to reproductive health care. And a few examples immediately came to mind. So one is that one of our public health insurance programs called Medicaid is specifically, well, a large portion of it is for people who are lower income and poor, living at or below the poverty level or slightly above it. And there is an option that individual states can adopt called the Medicaid Family Planning Waiver, which actually allows the state to provide family planning coverage for family planning services that go to a larger number of women that, at a certain percent, it could be 150%, 175%, 200% of poverty. So to expand access. Some states adopt that policy and some don't. And some studies have shown that there's a leaning toward states that don't adopt that policy, that those are the states that are the most restrictive when it comes to like access to abortion, for example. And then we also have another policy in our welfare policy, which is, cash assistance for the poor, where several states adopted a policy where if a woman was receiving cash assistance and became pregnant and had another child, the amount of cash assistance the state would give her would not increase, even though she had a larger family now. And that's not the whole country, but it tends to be in the states that don't support access or helps, with access to contraception. So a real contradiction, to say the least. And I just wonder if, what your thoughts are, and maybe if that brings you back to some of the policies in Japan.
Thank you for your comment. Well, in Japan, state does not support family planning at all, contraception, morning after pill, anything at all. But interestingly, the government start to provide subsidy to fertility treatment. So always attention is population policy. So not like US, we are really aging society. Yeah, around 20% of them are above 65 years old. So government trying to support fertility treatment, but not contraception at all, no matter whether Japanese or migrants. So the policy is really, in terms of contraception, nothing at all. And another scenario is abortion is a kind of income source for private clinics for several years. So even today, abortion pill is already under the screening, but still private doctors insist women should pay same amount as surgical operation, $2,000 only for tablet, because they said women do not know anything. We should supervise how to take that pill. So it's really, always doctor-centered policy, not women-centered policy.
Right. And here, it's interesting. So the pronatalist around population demographics, right? And the capitalist side that you just mentioned. And here it's heavy-handed in terms of religious and religious ideology and the politics intersecting with that.
I didn't include the fertility treatment topics in my survey, but during focus group discussion, I found many Nepalese asked about the subsidy system of fertility treatment in Japan. And actually, some of them are already using that money for fertility treatment because it's not free in Nepal, but they can get large amount of subsidy in Japan. So that was also interesting things what I found during focus group discussion.
Interesting. Do we have questions from the audience? And feel free to show your camera if you want.
While folks, hopefully some other folks might have some questions, but if you're taking a moment to formulate your question, I'm wondering if you want to comment a little bit on how, I know you ended your presentation with these really lovely images of the last month, right, that you've been here in New York and in Woodside and Jackson Heights. I wonder if you want to just comment a little bit as you've been doing this preliminary informal, information gathering, and now that you have IRB approval, obviously you can start the formal component of it. But have there been any interesting similarities or differences to field work that you've done in Japan, in like the Vietnamese community, and other communities, particularly I would say, involving Nepalese migrants, but I'm just interested in the experience so far on the ground, in the field, on the ground.
Thank you. Regarding abortion, I met a woman did abortion, a private clinic run by Bangladesh doctors. And she said the reason why she went to that particular doctor, she could get service on the spot. I think it's not legal in the United States because according to US rule, probably if she already decided abortion, she should make appointment at the first meeting, and then she can get abortion service when she go to the clinic or doctor the second time, right? But she said she knew the procedure well, but she wanted to get the service on the spot. So according to her explanation, she wanted to get the service similar to what she had in Nepal. But I'm not sure whether her understanding is right or wrong. But anyway, her explanation seems to be they are still seeking similar kind of service what they are familiar with. Even the abortion service is available in New York City. That is one. And the other thing is I found many young students living together relations because they are still young. And their relationship between their young couples are quite similar that of Japanese students. So most probably those unmarried population have more needs to get access to family planning. However, they have some difficulty to talk about these issues in ethnic communities, which was very similar to their peers in Japan. So most probably it will be more easy for the student health service to intervene to their discussion.
Thank you. Thank you. Yeah, and the landscape regarding being able to receive medication abortion in a single visit, in the same visit, has been changing here. I think largely propelled by the COVID pandemic and the switch over to access in many instances or circumstances through telehealth, telemedicine. But there have also been a number of studies that I think even preceded the pandemic that were looking at, I think there's some data from the UK and some folks here in the US that I recall seeing reporting findings in terms of administration of medication abortion without ultrasound. So just something, that's probably handled differently in different clinical settings, but is also evolving.
Yes. Yes, I also found a lot of difference last few years because of pandemic and also Obamacare. So in my questionnaire survey in US, I should be more careful about when was it, when she experienced it, whether it was 10 years ago or 5 years ago or last year.
Excellent. And it seems from our perspective, you've been hitting the ground running and have met lots of really great contacts already. So yeah, Kathleen, did you want to make a comment also, or?
I was just following.
Yeah, just open it up, or if there aren't other questions, we can thank you for taking the time sharing. We're really excited to see what you find out about similarities and differences in New York City. And I have a hypothesis that you might find different gaps in services in New York City than what you're finding in Japan, but they'll be really curious to see what comes.
And I think we know where you will be this weekend.
Yeah, the parade.
Right. Yeah.
I have to say, it's been so interesting with Professor Tanaka informing us of all of the interesting things going on. I think you were at City Hall, right? Downtown at City Hall with a group of domestic workers or organization representing domestic workers. And so I think by the end of your stay, you'll probably a solid New York City,
Right.
New Yorker.
We'll be a lot smarter. So thank you.
Great. Yeah. Thank you all for coming. We really appreciate, and thank you for a great presentation. And yeah, we can't wait to hear. Maybe we'll do another one when we have results and hear what you're finding.
Yeah, that would be great. We really look forward. Thank you, Professor Tanaka.
Thank you very much for giving me opportunity. Thank you.
Thank you.